Top Med Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Med Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Nick Majerison here. Welcome to Top Med Talk. This piece is taken from the 8th Australian and New Zealand Symposium of Perioperative Medicine Special Interest Group. Updates in Perioperative Medicine 360, which took place between November the 7th and the 9th of 2019. Hope you enjoy this talk, and if you do, don't forget to check out topmedtalk.com and make sure you subscribe to us on social media as well. More details about that to follow. Before that, let's enjoy this talk.
Well, how are you all? I'm Stephen Pavia from Brisbane. I've just run into a few mates that I've known for many, many years, so this is going to be a bit of fun. Not sure how I got a Guernsey to this because I'm an electrophysiologist, but certainly, patients are going to come through for your perioperative assessment with these devices in, and there's some new stuff coming and some interesting stuff that's changed. It's a little bit older. I work with Keith Brown and Warren McIntosh and McSorley and David Anderson. I'm not sure whether you know these people. And we do regular cases with the implantation of the devices, defibrillators and pacemakers and the like, with ablation. So let's just go through and see what we got. There's a heap of stuff we could talk about. We're not going to get through all of it. I think this is only half an hour before Carl gets up here and talks about the interesting stuff. But the leadless pacemaker is something you're going to come across. And why would we bother? Well, basically when you pace the heart or have defibrillator capacity, you have leads that connect the generator and the brains and the battery to the heart interface with leads, and this is really a weak link because stuff can go wrong. This sort of thing you might see once in your lifetime, but devices can get infected and then the leads can pull back and fail because they get hammered in the bloodstream, twisting and turning 100,000 times a day. They get electrical noise on them, and that can be interpreted as VF inappropriately if it's a defibrillator, so your patient gets an inappropriate shock. Therapy may be withheld, but they really do take an absolute tumbling in the vasculature. So the leadless pacemaker has been sorted to try and get rid of this lead requirement to connect the brain and the battery to the myocardial interface by just being a little bullet that's actually put in the right ventricle. Has anyone ever had any patients come through with this in? Yeah, there's no pocket. There's no lead, there's no surgery, everything's in the heart chamber. And there's a couple of them out there. One's been pulled, the one on the left's been pulled just because the battery was failing, but we're still using the micro. And essentially it's just a right femoral vein approach like we do on a daily basis, and just drop this thing in and hook it into with tines into the right ventricular apex. Really very easy to do, usually works, and pretty short. And if you compare it with our conventional approach, it's actually probably better. Now, this was the study that we did, so it was done with very experienced operators, but still it's at least as good as and probably better than the conventional approach. So there are big problems with pacemakers and leads, and certainly the leadless pacemakers take a lot of that away, but you can only do it in the right ventricle. So you've got single chamber pacing at all. It's very expensive. How do you pull them out? What happens when the battery runs out? Do you just leave it there and put another one? These are all the challenges that we'll face over the years. Certainly we're working in pigs in the States, so I put in atrial leadless pacemakers, and they'll be coming out in the next little while, but it's very, very complicated to try and link the two electrically, whether that be with Bluetooth or whatever from the atrial and ventricular. So it's very interesting. When does someone get one? Well, if they don't have any vascular access, obviously, and we've got to go by the leg, all single chamber at the moment, but as I say, we're developing dual chamber. Now, people may have come across this as well, along the same lines of leads being nasty and breaking and the weak link over many years for these patients that need the devices. We can actually put defibrillators, so we've talked about pacemaker, out of the vasculature. So this is on top of the chest, underneath the skin on the sternum with the lead, and then you've got your shocking piece right about underneath the arm at the back. This is the substernal approach, under the sternum, as you can see on the X-ray, where we plug a hole and go out with a trocar under the sternum. And at the moment, this one's been investigational. And the conventional ICD compared to the sub-Q on top of the sternum and the substernal, they're reasonable. Obviously, the conventional is our best, but it's a very large device, the sub-Q, and we use them now. And you get lots of inappropriate shocks because it doesn't sense as well. The lead's too far away from what it's sensing. It can be used usually, though, for people who are very young, who don't want anything in the vasculature early, who might have an inherited channelopathy, etc., that puts them at risk of sudden cardiac death. So you may come across that. Now, look, MRI conditionality is something else that, depending on your field, is interesting because, for resolution, to avoid radiation, really the treatment, the investigation of choice oftentimes. And it was just a no-go zone there for years. If you had a device, you just couldn't have one. The magnetic effect and the gradient, they have minimal effect. It's really the dissipated heat at the tip that's the problem. It can actually cause burning. And this can have horrible effects, particularly on a pacer-dependent patient. And so we've got these devices now that are MRI conditional, pacemakers and defibrillators, and some of them are in a 3T magnet, most of them in a 1.5, and their whole body. And we haven't had any trouble. I think that it's something you really need to be aware of because a lot of people are still coming with devices in that are conditional and they feel as though they can't have an MRI from their orthopod, etc. So it's really a very, very important point. Some companies went with a completely new lead structure and new generator structure to be MRI conditional, but others have just relabeled their older stuff. And that, to me, just suggests that it's a moving target. So if it was not conditional last year, your device may be this year. And this needs to be bounced off the implanting cardiologist, and that person needs to take ownership before the radiologist puts them in the magnet. Just in case there's redundant leads and things that people aren't aware of, and that can really create some heat. So you can have an MRI. Implantable cardiac monitors, these are loop recorders because, a lot of the stuff that we want to pick up in cardiology just happens intermittently. You've got a dodgy spark plug in your car stopping and it's fine at the mechanic. You drive out, it stops again. This is the sort of stuff we have with people fainting. And we like to be there at the time to ensure that it's not a cardiac cause, because if you do have a cardiac cause for syncope, you've probably got a 10% chance of really, really hurting yourself or dying within 1 year. And so these have been pretty small now. They're very small and injectable. And we just put them to the left of the sternum. This is an old slide here with one of the bigger ones, but they're pretty tiny now and they just sit parasternally. Takes about 45 seconds to put them in. The second indication now is for cryptogenic stroke, because if it's AF and you don't pick it up, they need a blood thinner, and you never know, because AF's mostly asymptomatic and it can cause strokes. And if you have one from AF and you're in sinus rhythm with the Holters and stuff that the neurologists do, as soon as you walk out the door, you might have AF again and have another stroke. So this study was done, and it really is very, very important, and it's formed the basis of the second indication for a loop recorder that's reimbursable, and that's cryptogenic stroke looking for AF, because we know that you can anticoagulate that, and people will do better in the longer term. I was in the lab the other day, and a nurse came round from the main operating theatre. This is a Wesley Hospital in Brisbane. Someone had gone in for a breast biopsy and the surgeon had removed and didn't really know what it was, and it was actually a loop recorder. Hence the relationship to anaesthesiology. I couldn't think of anything else. The anaesthetic person didn't know either, which was pretty rough, really, after they'd had all the tests and they took this lump out and it was non-malignant. So this is why you put them in. And this is what we see. You see pauses, and then this is all remotely sent to my team. The patient won't even know about this, and then we call them the next morning and say, your heart stopped. You need a pacemaker or a defibrillator. And there's all these wearables too that are coming now, and we're doing a lot of work with Samsung to try and get everything in the cloud with the stickers that you put on, so that you can have constant monitoring with very little intrusiveness with regard to the patient. And these are really limited by how long the battery lasts in these stick-ons. So monitoring is absolutely the way of the future, particularly for atrial fibrillation detection. This bit here you might have seen in other fields, but it's really important with regard to new stuff in cardiac devices, and it's just minocycline or rifampicin impregnated mesh that goes around the generator as we put it in the pocket in certain situations, because on the left we can see the implants, and device infection has gone up, as you can see on the right, a lot more than the number of device implants has increased. And why is that? Well, the patients are more complex now. I mean, 20 years ago, we weren't putting a lot of devices in people who were really, really, really sick, and that might be one reason why they're more susceptible to infection. But there's also more complex procedures, and that also increases the infection risk. And, infection is always a potential concern, but these devices are connected to the heart. And if you get infected leads, etc., well, you do very badly, as you can see with this slide here. Over a 3-year period, the risk of dying is horrendous if you get a device infection. Absolutely horrendous. Compared to sort of other nasty conditions, it's pretty bad. So we pay a lot of attention to infection, obviously, and the Tyrex is the name of this particular one that's available now from Medtronic, and there's been a major improvement in patients who get the Tyrex compared to a one-to-one study that didn't get it in what was perceived to be high-risk patients, such as box changes for generator replacement or a reoperation. So CardioMEMS is something else you might come across, and has anyone ever heard of this? CardioMEMS is something that I'm doing now in private. The public hospitals had hold of it for a while. We do it in a study situation with Abbott. I've done about 7 of them, and it's really simple. What it is that thing, and that's a pressure transducer that we just put in the pulmonary artery branch. It doesn't have a battery or anything, and it's hopefully lasts forever. It just sort of gets endothelialised eventually, in a pretty straightforward procedure, just like a right heart catheter. And it just sits there and it looks at the right ventricular systolic pressure waveform, and it's really, really sensitive. It's an incredible transducer. And then the patient just lies on the pillow whenever you like, once a day or once a week or whenever you want from home, and it automatically transmits that tracing to my nurse, and it can give trends. So that this thing here is something to predict a heart failure presentation. So here it is here. We just shove it in the pulmonary artery branch, and these are the sort of measurements that you get with PA, systolic diastolic mean, gives you the heart rate, and you can just see trending, even on a daily basis if you want. And there was significant improvements in the last big study with regard to hospitalisation on the left, and survival. And hospitalisation is a multi-billion-dollar industry, something that we want to sort of minimise. What happens when people come to hospital with heart failure is they can't breathe, and you hammer them with Lasix and they lose 1 kilo a day over 4 or 5 days, and then they go home until it all happens again. But there's a very, very slow progression toward those symptoms that prompt an admission. And the CardioMEMS is probably the first thing with the pressure measurement change that you can detect asymptomatic patient from home, adjust the medications, and they don't come to hospital because it can precede the hospital admission by up to 2 to 3 weeks. So this is an early intervention, and it's all remotely monitored, which is mainly what I do with all my 8,000 devices. They're all monitored from home. It's a lot of work, different infrastructure. They don't need to come unless they need to come. It can prevent things happening with lead fractures or atrial fibrillation detection. We can intervene without them having to come, rather than come for your routine check once a year without remote monitoring from home and say, oh, what happened 3 months ago? Are you okay? Because you had AF for 4 weeks. Did you have a stroke? That was lucky. We do it on a daily basis. And this is another example of putting this on the end of our remote monitoring repertoire so that we can keep people out of hospital and monitor them from home so that we practice medicine that is everyday medicine from home, rather than I'm only interested in you as you're sitting in front of me once a year. So it's fantastic. And the reason in which this works is because this is complicated, but essentially you just muck around with their tablets. PA pressures go down, come off, they come up, you put them up, and it really works. So it's a lot of work, but not with the patient in front of you, and certainly not as an inpatient with a pulmonary edema episode. Cardiac resynchronization therapy, people know about that? People see people with bi-V pacing, cardiac resynchronization, lead in the coronary sinus, all this sort of stuff. The whole thing is that people with weak hearts do badly, people with stronger hearts do better. We give them lots of tablets to improve, and there's Entresto now, which is a really sort of major improvement, but it's not the big silver bullet. It's better than the other ones. We need people to have stronger hearts. And so if your heart is weak, the left ventricle, that's normal, that's not. There's an extra opportunity to intervene if the way in which the heart is weak is like that. Sort of rocks, desynchronous, and the dysynchrony surrogate is something as simple as an ECG measurement of a left bundle branch block. So if your heart's shagged, that's okay. But if it's shagged and doing that, there's an extra opportunity. So the device that you would put in the defibrillator protects sudden death in LV dysfunction because people tend to suddenly die. But there's an extra opportunity if there's left bundle branch block to try and use the electrical energy that paces the heart or shocks the heart to trick the heart into squeezing better. Because if I can put a lead here and then a lead here and spark more simultaneously, it gives a better pump. That's very simply put. And that's the whole idea of trying to resynchronize with LV dysfunction and left bundle branch block. It's not going to work if you don't have the left bundle branch block or the dysynchrony. So we're changing an electrical energy that's usually used for pacing or shocking into something hemodynamic. We get to the left side of the heart because the right heart is easily accessed with our normal leads in the coronary sinus, which is basically a little hole in the right atrium, and we go backwards epicardially and try and find a vein that's suitable. Otherwise, surgery. And essentially you've got 3 leads. So you've got your right atrial lead, your right ventricular lead, and then this other one sort of sticking out there in no man's land. You get a venogram, see if there's a target vessel, you pop it in, it's just over the wire. And you don't want the bottom. The top one wouldn't work, but there's a nice left bundle branch block, so that's just sort of a mouth-watering opportunity if you're putting a defibrillator on LV dysfunction to try and get a third lead. And here you can see on the left in V1 there's sort of wide QRS, but you're pacing, and that's because it wasn't capturing. But when it did capture with the increased output, you can actually see it tightened up. And this is what you're looking for. So we spend a lot of time trying to tighten up the ECG in the left bundle branch pattern. And a really good case would be like they come in at 190 milliseconds in left bundle and they leave at 120 because they're bi-V paced. And that is probably the single most important predictor of response. So there's all these fancy echo things that don't really work. But going back to the simple ECG, lots of studies here showing improvement in survival and quality of life and LV function. So how have things changed? Because I started doing this in the Cleveland Clinic in the 90s, and we were using standard leads, and it might take 8 hours, and it was just shocking. It's really good now. There's special leads, and there's algorithms. So you've got to choose your patient, you've got to get the lead in, you've got to get it in the right spot. But then there's all these other things that I work on with companies around the world to get algorithms that improve the outcomes even further than a good spot in the right patient. So you can see there's sort of dodgy leads that we're using initially on the left, but now there's all these fancy ones with multi-poles and twists and turns to sort of get good position, good stability, and a wide range of poles to pace the heart, if not all of them work, or some give diaphragmatic stimulation. Then there's another algorithm here. Usually you just pace between two poles, but this is multi-point, so we're pacing over a larger area, so you're recruiting a larger number of myocytes into that, trying to resynchronize. And that's something that Abbott's worked on very nicely, and so you get a more confluent depolarization of the ventricle. Then this is another one we've worked on with Abbott, and Medtronic have one as well, where you actually not only look at the VV, but you look at the AV, because you have to capture every time. You can pace, but it may not capture, and AV delays vary depending on standing up, sitting down, running up a hill. So there's algorithms now that determine that to make sure that you bi-V pace all the time. And you can see here how this helps. So these are the same patient, same lead position, intrinsic, just the bi-V, and this is the QRS duration, our surrogate for improvement. The multi-point brought them down to 142 milliseconds, sync AV down to 130, and together 123. So not only the patient, the tool, and the correct position, but these algorithms are incredibly important, which means that you can't do what 95% of the world does and put in the device and say, off you go out of the box. This needs work for follow-up, and it needs to be adjusted just like you do with medications. You need to adjust your parameters in the way in which you program these devices, because it makes an incredible difference. So that's a summary, and I might stop there. Okay, thanks very much.
Hi, Top Med Talk friends. I wanted to let you know that we have some very exciting news. EBPOM London 2020 is on. We will be having the meeting. It will be the original dates, June 30th through July 2nd. We're going to mix it up a little bit, so be sure that you visit our website at ebpom.org. That's ebpom.org. You'll get more details. We are going to be offering content, on-demand content, as well as live content, all the most amazing speakers that you ever hear at all of our EBPOM events. So that's super exciting. It's only 150 pounds, and you will have access to all of our content for that. So be sure to check us out, again, ebpom.org. We're super excited about everything we have to offer this year. All of our same speakers, all of the same quality that you would normally get at a live meeting in person, but you can stay in your jammies. So be sure to check us out. Thanks so much for listening, and hopefully we will see you at Live from London, EBPOM 2020.